Welcome, medical students. Today, we're going to use this explainer to transform you from being, kind of intimidated by all those endless beeps in the operating room into highly skilled physiological detectives. Look, the whole purpose of monitoring is to augment your clinical observations. But as these monitors have grown more and more sophisticated, they've also brought a ton of additional complexity. We really need to cut through that noise.
So we're going to track a patient's surgical journey sequentially today. Here is our agenda. 1. The pre-induction safety checklist. 2. Clinical signs and deceptive ECGs. 3. Blood pressure, non-invasive versus arterial. 4. Oxygenation and waveform capnography. 5. Temperature tracking and metabolic safety. And finally, 6. Our essential take-home clinical points. Let's dive right in.
Section 1. The pre-induction safety checklist. Before you push a single drop of induction agent, we have to anchor ourselves in basic human diligence.
You have to quickly establish your baseline by running through this absolutely critical checklist. First, guarantee you actually have the correct patient in front of you and note their age. Second, confirm that the machine itself has been recently serviced and calibrated. Third, ensure your environment is appropriate. For instance, do you know for sure if your equipment is safe for an MRI suite? And finally, make sure your alarm limits are specifically set for the patient on the table. To direct your treatments properly, you absolutely have to know that what's being measured is actually accurate.
Okay, moving on to Section 2, Clinical Signs and Deceptive ECGs. Once the surgery begins, the monitors are going to light up like a Christmas tree, but never ever forget that your first and most reliable diagnostic indicator is the patient right in front of you. Your principal aim is to ensure the patient's tissues are getting an adequate oxygen supply. Clinically, a really simple physical observation of pink skin, warm fingers, and a good solid pulse implies there's unlikely to be a major cardiovascular problem. If you press on a finger for 3 seconds, a capillary refill of under 1.5 seconds is considered completely normal. But if that refill takes greater than 5 seconds, that is highly indicative of shock.
But wait, here is a massive pitfall. You'll be staring at the electrocardiograph, the ECG, which measures the electrical activity of the heart at the skin surface. Now, the ECG might display perfectly regular electrical activity, but it does absolutely nothing to guarantee there is any actual cardiac output. And that severely limits the ECG's usefulness as a standalone monitor. Because, think about it, during emergencies like ventricular fibrillation, cardiac tamponade, or severe hypovolemia, electrical activity can still be chugging along with literally zero cardiac output. The monitor might actually lie to you. That makes your direct physical observation of the patient perfusion absolutely crucial.
All right, Section 3, Blood Pressure, non-invasive versus arterial. Moving on to hemodynamics, monitoring BP is our way to ensure tissues are actively receiving that vital blood supply.
Let's apply this to a quick case. Imagine you have a critically ill trauma patient on heavy vasopressors. Normal, non-invasive methods like an automated blood pressure cuff, they simply won't cut it. We have to upgrade to invasive arterial blood pressure, or IABP. That continuous red arterial waveform gives us this amazing beat-to-beat visual analysis of the patient's cardiovascular status in real time. It gives us the crucial cardiac output and volume data we need.
However, it's a real clinical balancing act. We have to critically weigh the absolute necessity of an arterial line, like in scenarios involving massive blood loss, neuro procedures, or needing frequent blood gases, against the severe complications it can cause. We're talking invasive complications here, like distal ischemia, thrombosis, hemorrhage, infection, and sometimes even skin necrosis or neurologic injury.
Let's shift gears to Section 4, Oxygenation and Waveform Capnography.
Next up is the respiratory system. We'll start with the ubiquitous pulse oximeter, which analyzes changes in light absorption to measure hemoglobin oxygen saturation. It actually blinks around 120 times a second. But as a sharp medical student, you've got to be aware of surprisingly common factors that can totally skew these readings. Cold extremities, motion artifacts, the literal absence of a physical pulse, physiologic states like methemoglobinemia, certain medications like methylene blue, and even something as simple as the patient's nail polish can dramatically alter that light absorption, meaning a trendy manicure might just give you a completely false reading. Let's apply this to another case study. Your intubated patient suddenly triggers an alarm. By visually deconstructing a normal capnography waveform with its clear expiratory upstroke, alveolar plateau, and inspiratory downstroke, and comparing it to the live data coming in, you become the detective. Do you see a sudden, complete loss of the waveform? Boom! You can instantly diagnose a disconnected, dislodged, or kinked ET tube. Or are you spotting a classic shark fin appearance?
Your patient is highly likely experiencing bronchospasms, like what you'd see in asthma or COPD.
We are almost to the end. Section 5. Temperature tracking and metabolic safety. The final physiological system in our case study today is thermoregulation.
This is a highly critical factor for maintaining perioperative metabolic safety. The body naturally separates its inner core temperature, which includes the major organs and is measured via a PA catheter, the nasopharynx, tympanic membrane, or the rectum, from its peripheral temperature, which we usually just assume is skin temperature. You have to keep in mind that the induction of general anesthesia typically causes vasodilation, and that leads to a subsequent decrease in that core temperature, even if heat is currently being lost.
So here's a really brilliant diagnostic rule from the source material. Low cardiac output states are characterized by a reduction in peripheral temperature as a direct result of vasoconstriction. Therefore, if you are observing a core to peripheral temperature gradient that is greater than 2 degrees Celsius, it strongly indicates low cardiac output.
We must strictly guard against hypothermia, which is defined as dropping under 35 degrees Celsius. It's especially likely in kids, the elderly, or doing really long surgeries with open abdominal cavities and massive fluid infusions. Why does this matter? Because it sparks a dangerous metabolic cascade. We're talking reduced metabolism of drugs causing delayed recovery, severe coagulopathies, acid-base abnormalities, acute renal failure, and potentially life-threatening arrhythmias.
And finally, Section 6, Essential Take-Home Clinical Points. Let's wrap up this case study and consolidate what we've learned as physiological detectives today. Our source text profoundly summarizes the ultimate goal of the operating room: monitoring and precaution are better than cure. It's about meticulous, proactive monitoring. It's about understanding exactly what your equipment measures. And it's about maintaining rigid safety precautions. Doing those things will always beat attempting to cure an active, spiraling crisis.
So I'm going to leave you with this final provocative thought to take into your clinical rotations. When an alarm inevitably sounds, are you simply going to read the numbers and treat the blinking monitor? Or will you remember the deceptive ECGs and those false pulse ox readings and use your clinical intuition to truly assess and treat the patient right in front of you? Thanks so much for joining me on this explainer today.